Okay, so let's come back. I let you go a little bit longer, which means we're going to have to be efficient in our reporting. And I've also learned that if you keep talking into the microphone for a long time, everybody else generally stops pretty soon. And look at that, it worked once again. So I purposely let you go because I heard all the conversations and you were never going to wrap that up. But let's go very quickly because we also want to get question 2 in and we have a hard stop at 5 o'clock. So let's start with table 2 here. Who's, give us your top 2 observations. Yeah, I think what you said was perfect.
What I said was perfect?
Sure.
Well, I'm sure it won't be when it's disseminated throughout the room.
That's what's, that's why they have editors.
I mean, the difficulty I was having, and maybe some at the table were having, although I won't speak for all of them, is how to move from a sort of social determinant of the month approach as a tool for change to a more common sort of systemic approach, of which health literacy could be one of those tools, and Andrew was arguing that would be a great tool for that. But I'm sure others would argue that their particular social determinant of the month would be a good tool too. So the issue that it seemed to me, and we didn't really have time to discuss this, so I won't say to us, but to me at least, was what's the sort of common glue that we can present to those who run the academic world? And the one that strikes me as most important is do things that enhance community engagement in your curriculum. And it doesn't really matter that much about which particular set of social determinants, because they're all there in the community that you happen to have expertise with. If you have the opportunity to engage the Canyon Institute, then health literacy might be a good one for that, but that there are a variety of things, but that I'm looking for generic solutions. What do you tell deans to do? And I think they're coming around to understanding that you need to get out of the ivory tower and into the community, and then that there are available a set of tools or constructs that you can use within that community framework to help revolutionize your curriculum. I'll say no more. But
thank you very much.
I emphasize that I'm not speaking for the table, so I have no idea what they believe.
Let's go to this table. Whose number where Joanne is at?
Yeah, Michelle Trosett representing table number 2. We had a wonderful dialogue. We kind of went all over the place. But I think some of the key learnings were when it comes to preparing for globalization, that while there's a lot of emphasis on cultural competence and a lot of literature out there on that it's really important that we always take it back to that individual patient, the N of the patient, and to ask key questions. You know, what are your needs? You know, because you can make assumptions about cultural and globalization as well. Especially we talked about in the face of the electronic health record, really losing that consistency. So again, do we need some common practices across all professions built into our templates or the things that we use electronically? That's going to be really critical to have this come to fruition. And then we had some lovely conversation about health literacy and teach back based on the presentation, and thought that would be a really great core competency across all professions. And it's also some low-hanging fruit we could do quickly. So we talked about that too.
Yep, thank you. Let's go to this table here. I can't, number 5.
We certainly talked about the fact that almost every place that you live, not only in the United States, but in any country and across the globe, has a variety of cultures, and that it is impossible to truly educate anyone to function competently to practice globally and understanding all cultures and all languages, but that it is very important to recognize that there are differences, to have sensitivity to the cultural differences, to value those differences, and to be educated to use interpreters and others, but to certainly have the individual validate what their values, beliefs, and practices are, and not to make assumptions because you have some knowledge of having worked with some individuals from the same culture.
Very nice. Thank you. Table 6 in the back corner there.
Actually, we were wondering if Malcolm could share his Global Health of the Month calendar with us. So we tried to identify transferable skills or foundational elements that would apply to the practice globally, interpreted either as whatever community you're in that has crumbling boundaries and is becoming more global, or due to the impact of what's happening elsewhere in the world, having a greater influence on your own local sphere. Two of the components appeared to be cultural sensitivity, or whatever the appropriate term for that is now. It does seem that at least we were able to identify some elements of that in medical schools mandated by the LCME, as well as the Joint Commission, but we were unaware of other disciplines requirements for that training. The other area that we did identify that would provide foundational elements and transferable skills are many of the components of health literacy.
Very nice. Thank you. And last but certainly not least, the table I can't see the number on. 7. 7. Thank you.
There we go. So our table started out by exploring what it means to move this question to the community itself. A brilliant idea of, instead of our coming up with the solution, taking it to the community and saying, what would the solution be? And one opportunity was having a checkout. This was designed by the community, so the health provider has half a page and the checkout person has the rest of the page, and they come back to the health provider with all the things that were actually missed, misunderstood, not covered fully, sort of a check on the communication. We went from that to, so how could we think about this in education as something doable? And decided that we liked the different competencies, but we thought we should just pick one and really focus on that across all the disciplines. So our particular one we were playing with was the teach back, again, as being kind of a key thing. And finally, we started to explore, but sadly had to stop, the question of sustainability. You know, even with focusing on one, how can you sustain that, and why do people not sustain it? And wondered about the continual pressure on the health system to shorten time with patients, to shorten encounters and the cost and the time, and how much that affects sustainability of these initiatives. Anything else from the group? Okay.
All right. Thank you very much. It's always fun to be in a room of smart people, isn't it? So that's fabulous, and I'm not going to respond to any of those in the interest of time. But what we've decided to do is to take this next question and let's just do a real rapid fire, whole room, throw out your idea discussion, because the question is, and you all already have begun to answer this in your previous discussion, how might health literacy be globally integrated into health professional education to improve communication in a globalized world? So first responses, somebody's got something pressing, because I heard answers to this already as I circulated around the room, and Cliff and Jennifer, include yourself in responding to this, please. So how would you do it? And the one way I always like to frame this question is, if you had a magic wand, right? So take those limitations out of your mind and give yourself a magic wand. How, in fact, would you be able to do this? Yes, Joanne.
I think this goes back to patient-centeredness, and that in our concept of patient-centeredness is that we must be assured that the patient really understood what we were saying. First of all, that we understand them, right? So that's the first questions, and we talked a lot about that. Number one, do we understand them? But number two, do they understand us? And that's what our communication is about. And if that just becomes foundation, then you don't walk out of the room without having that comment back that assures you that, yes, you're on the same page and what you've said is understood and can be followed, can be acted on.
Thank you. Dr. Campos.
Yes, I was thinking about the discussion that we had this morning about the community health workers. In the case of Brazil, I think that the community health workers clearly is an example of translation, not from Portuguese to Portuguese, but from the medical jargon, as was said here, to what the people understand. So I think that the idea of the community health workers as translators or is important.
Yep, the proven evidence is clear. You are correct. Yes, ma'am.
Brenda Zeeler, University of Washington. I like Dr. Coleman's idea of using simulation and standardized actors to get the students in the habit of doing this. But then I would like to say we need to do some faculty development, staff development, preceptor development, because that's who our students are learning from. If you want this to stick, it has to get out of the simulation lab.
Indeed. Other thoughts? Yes, sir. Thank you.
I think because health is a human right, that it is absolutely necessary that you start early, and that already in the basic school, in the primary school, in the secondary school, there is attention population-wide for health literacy. I think that you have to start over there. So that's not a medical issue, that's an educational issue. And secondly, I would suggest as much as possible to integrate health literacy in any of the training elements, and especially in the provider person or provider patient encounter training and the communication training, that health literacy is a key concept. But that's also a key concept when we discuss the learning of certain groups of diseases, that we all the time do this from the patient perspective and see how we can communicate. And so then breaking bad news becomes a specific exercise where health literacy, with all its contextual components, will be really, I think, very much in the picture and in the center of the exercise.
Yes. Thank you. Yes, sir.
To a friendly addition to what Michelle said before, it seems to me educationally a key issue is breadth of experience, so that across class, across ethnicity, and enough time to really understand the differences between the people. Without that breadth, then you don't get calibration, and calibration is key for understanding across cultures.
Mm-hmm. Yep, involve people. Amelia.
I was privileged to be involved in something the World Health Organization did in Nigeria, where they used expert patients, similar to what we do in simulation, where we bring live patients. However, the difference was that the patients understood their disease process and they understood what they should expect from the providers. So when they come in and the provider clocks them, they now rate the provider and say, thank you for attending to me. You asked me the following questions. Those are what I expected that you would ask me. However, you didn't. Wow, that was an eye-opener for the provider. First of all, some of them were like, they wanted to get up and walk away.
Yes.
So I like that approach. If we can be able to integrate it into pre-licensure education, it would be very wonderful, because sometimes we go to the community, we use translators, And a lot of what we're saying to the clients are missing in translation.
Yes.
So that it will just make us more sensitive
Yes,
to the way we
indeed.
communicate with clients.
Thank you. So we have 60 seconds. Cliff, do you have 15 seconds worth to say goodbye?
Sure. Yes, I would just say my parting thought would be that to answer the question, I think that providing understandable, actionable health information is an ethical imperative, and I think that we need to include that in the ethical foundations of our trainings for all healthcare professionals. I believe that access to understandable information is probably the greatest health disparity that we're facing right now. So perhaps that by modifying ethical standards to focus on communication, we could approach it globally.
Jennifer, thank you, Cliff. Jennifer, 15, quick closing comment. Microphone.
Completely agree with everything Cliff just said, and would also just remind myself and us that the greatest indicator of health disparity is always going to be economic disparity, as far as we've seen in the history of the world. So when we are choosing where to invest our time, money, and energy, remember those health disparities or health inequities.
Fabulous. And that's, yep, there you go. See? People on the webcast can't see that, sorry. And I'll just say thank you all very much. It's been a fabulous day. I look forward to tomorrow. Thank you to the staff. And I just want to let you know that the Institute of Medicine actually does have a roundtable on health literacy, which is like a forum, but we arrange our tables differently. I've been waiting all day for that one. And then you have some closing notes, but really thank you. It's been a fabulous day.
Well, on behalf of the staff and the planning committee, thank you to everyone who's had the tenacity to stay and the personal energy to stay through the whole day. We started out talking about what we have to do differently. We were inspired by what we heard from Professor Campos, and we've talked about what it means to our curriculum and some specific and general initiatives that we may want to carry back to our various organizations and places of employment. What we thought we would do for this reception time was really give you something we couldn't do in a closed room session like this. And that is to give you exposure to some of the highly scalable, innovative technological approaches for the use of simulation in health professions education. And so upstairs we've gathered for you 23 different examples of educational applications of simulation that's been brought together, pulled together from some of the best that we've had at the Society for Simulation in Healthcare annual meeting, and so it has an international bend to it. But I hope that you will come upstairs, two floors up, third floor, and the stairs is right here to be heart healthy. We should all walk up those stairs. And we hope that you will join us to see what's there, and we'll talk a little bit about that tomorrow. We start tomorrow. Breakfast is available starting at 7:30, and we will start at 8:20, not 8:15, not 8:30, but 8:20. So once again, thank you very much for your time and attention today. Great interaction. Let's keep it going upstairs.